At Champion Health System, we are committed to transforming lives through effective, medically supervised weight loss. Led by Kelcie Willis, DNP, FNPC, our expert approach to obesity treatment combines advanced medication and personalized care to help you achieve lasting health.
Those types of things. Obviously, this is not meant to be all-inclusive, but it's definitely a passion of mine. Most of you know, some of you that are new don't. I have, over the last 2 years, lost 175 pounds. So this is something that is absolutely a need in the medical community, and we all see the benefits of weight loss every day with our patients. So if you have any questions, please feel free to ask at the end, or if you need to interject. I just want everybody to kind of be able to talk about things. So today, the main things that we're going to cover is the first half. Why is obesity problematic? Why what we've done in medicine, what we've always done, doesn't work. Changing our approach to medical weight management, options for medical weight management, dietary and exercise recommendations, and then how to get started. When I created this PowerPoint, this was geared specifically towards patients. So some of these things you guys already know, but it's important to kind of have a little review. So when talking to a patient, they say, why is my weight a problem? My labs look good. I'm healthy. I'm not having any issues. A lot of times we don't see that in cardiology. We see all of the things that weight begins to take a toll on: heart health, vascular health, overall quality of life. But some patients are very resistant to, my weight isn't an issue. So how to approach, if the labs look good, our health is good, we're active as we choose to be, then what does our weight matter? Weight is a very insidious process. It is not something that is, like a stroke, that when it happens and boom, you see all of the implications and the issues after the fact. We begin to slowly develop these things over time. And so a lot of times patients will not even realize how much their quality of life has been limited by their weight. I had a patient literally 2 weeks ago who said, I did not realize that I could not have to deal with being out of breath anymore, just tying my shoe. She had just accepted the fact that tying her shoes made her out of breath, and that was just what it was. And she's lost 20 or 30 pounds, and she said, wait a minute, I can do this now, and it's not an issue. So there is a little chart here that talks about just a lot of the different things. And this is a very good visual for patients to see the different ways that obesity can impact our body over time and slowly. So for years in medicine, we have approached obesity as an issue with willpower. The attitude in the medical community has been essentially put down the fork and move more, and you will not have an issue with your weight. This leads to a lot of shame, a lot of issues as far as people wanting to address their weight. And it leads to a lot of issues with us as providers wanting to ask those questions. We don't want to make people feel badly about themselves. That's not why, we got into this. We want to help people. I have said, I try to tell any of the students that come through with me, the number one group other than smokers that show the most shame and hide a lot of their activity as far as their habits are people who are overweight and obese. It very much is a emotional issue when you ask people that question. And the approach from the medical community has added to that, kind of making people feel like, well, you're just lazy and you can fix this issue. But if we're truthful, a lot of the health implications and health issues that people have, part of it is due to genetics and their body, and part of it is due to their lifestyle choices. And we don't quite shame them the way that we do people who are overweight. So this has kind of led to this big stigma. It leads to avoiding the topic, delays of care, development or progression of diseases to the point of no return. And then we're kind of fighting a losing battle. So the truth behind it is it's about 50-50. Losing weight and maintaining your health requires a ton of personal accountability, dedication, determination to those consistent habits day in and day out. And it does not matter what intervention you use. If you are strictly diet and exercise only, all the way to bariatric surgery, if you are not 90% of the time giving that day in, day out consistency, it is not going to work. But we have also found that obesity is a very complex, multifactorial chronic health process, and it takes addressing a patient on many levels to actually combat obesity. Their mental status, their emotional connection to food. Are they impulse eating, binge eating, emotional eating? Are we dealing with issues with poor nutrition because of poverty? There are so many other areas that we kind of have to address individually for each patient. So a little bit of the genetic metabolic process behind it, why putting down the fork simply doesn't work with a lot of our patients. They come in and they say, and we are all realistic. Patients will lie to you. They will tell you, oh yeah, I'm doing everything. And you can know when they're not taking the personal accountability. But we also have seen patients that say, okay, look, here is my food log. Here is my water log. I'm working out every day. What's going on? So we have a compensation mechanism in our bodies that essentially our bodies do not like to change. And that has to do with every process in our body across the board. And so after patients initiate a weight loss program, they've done a reduced calorie diet, they're doing everything they need to do, metabolic adaptation may result in increased signals for energy intake. So the body kind of starts to panic and go, wait a minute, this is different. I don't like it. I'm having to do a little more work. And so your body recognizes your efforts to lose weight and decrease your calories, and it starts to try to accommodate and hold on to everything that you're taking in. So your hormones increase, like ghrelin, amylin. They begin to increase your hunger drive and decrease your satiation or your satiety, making you crave more food and deal with hunger more often. So this is a little bit of some of the hormones and peptides that our body naturally creates. We will touch more on GLP-1 in our second half, but it's super important when you're talking to patients about these GLP-1 medications, which we've all by now heard of, that GLP-1 is a naturally occurring peptide in the body. And this peptide helps regulate our fullness, our satisfaction, our hunger drive, and kind of our brain's response to the food that we have already taken in. It essentially manages our brain's response and says, you are satisfied with what you have, you do not need any more. So now we're going to kind of get into some of the options that are available to patients. Obviously, each and every patient is different. Each and every financial situation is different. I have some patients that pay $600-700 a month for GLP-1s. I have some that the $25 for phentermine is a stretch, and everything in between. So much of tailoring medication management for obesity is meeting them where they are financially as well, because a patient is not going to be compliant with a medication that's $1,200 a month. So some of our oral options that we're going to look at today, metformin, phentermine, orlistat, Qsymia, and Contrave. Those are your big ones. Then we will get into the injectables and surgical options in our next meeting. So metformin is a tried and true. It works by decreasing the amount of glucose released into your bloodstream by the liver. It increases your body's ability to use glucose for energy rather than storing it as fat. It is a typically once to twice a day oral. You usually start with 1 tablet twice a day, and you can go up to 2 tablets twice a day with food. The biggest issue with metformin and why it's not one of my favorite medications to help with weight loss is lots of people have horrible GI side effects. Nausea, gas, upset stomach, diarrhea is significant with a lot of people with metformin. You can mitigate this a lot of times by the extended release version, but some insurances don't cover it. It's starting to become more common now to cover it. So there's that. It is by far the most affordable. A lot of times it's covered entirely by insurance. And even without insurance, it's about $10 a month through GoodRx. All of the studies have shown that metformin, you can lose up to 2 to 3% of your total body weight with combined diet and exercise efforts. So those who should not take this without proper guidance, those with known renal disease, those with known liver disease. Make sure that your patients are always taking this with food, and if GI issues persist, you can do extended release. It's usually very easily accessible. Patients can usually pick it up the same day. Oh, let me go back. Hold on. Okay. So, phentermine is your next option. Phentermine is a stimulant to the central nervous system, and it helps decrease appetite. It is usually an oral tablet or capsule. It's usually once a day at the first meal. Because it is a stimulant, the most common side effects are dry mouth, difficulty sleeping, feeling jittery, and heart racing. It's usually very affordable with or without insurance, and typically even without insurance, it's around $20 a month. On average, the patient can expect to lose about 3% of their excess weight in the first month and 5 to 7% of their excess body weight in the first 6 months with diet and exercise. So because this is a stimulant, people who have uncontrolled high blood pressure, heart arrhythmias, who drink a ton of caffeine. If you have a patient who's just drinking 3 Red Bulls a day, they do not need phentermine. Who are on another stimulant, Vyvanse, Adderall, ADHD meds, and those with a history of addiction or substance abuse, because it is a controlled substance. Ways to manage side effects with phentermine: lots of water, 64 ounces a day. Do not drink excess amounts of caffeine or take with other stimulants, and stop if palpitations or elevations in blood pressure occur. Usually no issue with getting this medication either. They can usually get this on the same day as well. Just a quick little note that I have started doing in practice with phentermine. A lot of providers, myself included, going through school when we learned about this, are very quick to throw out the Adipex dosage, 37.5, have a good day. A lot of patients that I'm seeing that are on phentermine are doing very well with a stepwise therapy instead, and doing 15, 30, and then 37.5, extending out that dosage as long as they are losing 1 to 2 pounds a week. That way, they have a little bit more time to work their way up like these GLP-1 programs do. So just kind of something to keep in the back of your mind. Orlistat, also known as Ally, it causes excess fat consumption to be excreted into the stool. It's taken orally, 1 tablet 3 times a day, at or up to an hour after each meal. The biggest issue with Ally is because it causes fat consumption to be excreted. The more fat that's eaten, the worse GI side effects we're going to have. We're going to have urgent bowel movements, oily diarrhea, stool incontinence if they're eating a high-fat diet. It may be covered by insurance at the prescription dose, which is 120. And if not, there's an affordable over-the-counter version at 60 milligrams, and it's around $75 a month. They have this at Walmart, Walgreens, Target. Most studies show that with diet and exercise, most patients will lose 5 to 10% of their body weight in combination with diet and exercise. So it's actually a much higher number than I expected. But again, a lot of patients are not quite committed to that low-fat diet, and so they have a lot of GI issues. Anyone who has had malabsorption issues, so your post-bariatric patients, especially gastric bypass, gallbladder patients who have had issues with their gallbladder or have had their gallbladder removed, those who have had an organ transplant or are on cyclosporin are not a good candidate for Ally. Managing side effects, committing to a low-fat diet is huge. They have to, or they are not going to lose weight the right way. They may be losing it, but they will also deal with major malabsorption, major dehydration, and just feeling awful across the board. Make sure they're drinking plenty of water and minimizing snacking between meals. It is available, like I mentioned, on demand at most retail stores over the counter. And as far as we know of, there's no issues with back order or supply shortage that we're seeing in some of the other meds. Qsymia is a combination of extended release topiramate and phentermine, and it's a lower dose phentermine. So even though you still need to be mindful of blood pressure issues with patients, this is a better option because it is not a quick burst extended or instant release. It's a low dose or extended release. It helps work on the sensors in the brain that help regulate hunger, cravings, and satiety. You take this once a day, usually in the morning. Most common side effects are nausea, dizziness, changes in the way certain food tastes. A lot of patients will come back and say, hey, I really don't like this because I can't drink my Diet Cokes. For whatever reason, carbonated beverages, they have a hard time with. And dry mouth. It is usually covered by insurance at a lower cost, but if they have no weight loss coverage through their insurance, they have a program that you can mail order pharmacy directly through the pharmaceutical company, and it's around $75 a month. On average, with diet and exercise, patients lose 10 to 11% of their excess body weight. Patients who need to be monitored more closely, or those who do not need to take this medicine, are those who have an untreated overactive thyroid, which obviously, if that is happening, typically we're not going to see issues with weight, but if we are, it's going to be the opposite direction. Those who have an intolerance or allergy to Topamax or phentermine, those with uncontrolled blood pressure, and those who have glaucoma. You are going to manage side effects by only taking the dosage and frequency that is prescribed, staying well hydrated, no excess caffeine. Constipation can be a side effect, so stool softener as needed. This typically does require a PA with insurance approval, but a lot of insurance programs, if they cover weight loss, do cover this. Pharmacy may need to order it because a lot of times they don't keep this in stock, but there's no shortage, so they should be able to get this. And our last oral option of the day, and this is one that has been kind of new to me, but that I've gotten a lot more experience with over the last couple of months, is Contrave. It is a combination of naltrexone and bupropion. So how this medication works, it acts on the pleasure or reward craving sensors in your brain. It minimizes craving and desire to eat and snack. So it's got that good Wellbutrin component that helps with smoking cessation. It's also got the naltrexone component that helps with cravings as far as drug use. And so this is actually a pretty novel approach. It's taken orally once a day. The most common side effects are GI, nausea, constipation, diarrhea, headache, dizziness, dry mouth. This may be covered completely or substantially by the insurance company with a PA. If it is not, it can be obtained through a mail order pharmacy for a maximum of $99 a month through the insurance company itself. The pharmaceutical company. So typical weight loss with Contrave is around 5%, but a lot of patients lose more if they're doing concerted dietary and exercise efforts. There just aren't as many studies on this.
Kelcie?
I hope that she knows that we can't hear her.
Kelcie, we can't hear you.
Can't hear
Why is it echoing like that? That sounds
I'm
awful.
texting her. I just told her we can't see anything.
Okay. Why does it echo like that? Like, that sounded awful. Whoopsies. I'm gonna go this way since intermission, I guess.
Hey guys, I'm so sorry. My computer decided to shut it off in the middle of my presentation, so give me 2 seconds and I will pull it back up, okay?
Okay, thanks.
He's eating healthy with the weight
You're
loss.
shaming him.
Yeah, exactly.
Okay, well now that you put it like that, just give me that bucket now.
Hardcore shaving over here.
Dr. Roger, they got fried chicken.
I know. Like, on weight loss and with hash browns and mac and cheese. Like,
And what is this, an
I'm not
apple
complaining.
cobbler?
yeah, like, wow, that's a great weight loss right here. I felt like a fatty out. This was kept piling on my plate.
I am not complaining.
All right, back to it. Can everybody see okay?
Yep.
Okay, cool. Let me get through this. Okay, so you can go through the pharmaceutical company itself to get Contrave for around $99 a month, or a maximum of that. So those who should not take this, those who have known anxiety and depression, who are on well-controlled mental health regimen, we don't want to throw Wellbutrin into that unless they are willing to be very aware of their potential side effects, monitoring for suicidal thoughts, depression increase, etc. Those who are chronic opioid users because of the naltrexone component, those who are at an increased risk of seizures or seizure disorder, those with liver disease, uncontrolled high blood pressure, those who use alcohol to excess, and those with a known eating disorder. Managing side effects, you take only the doses prescribed to you at the interval prescribed. This is a medication that you titrate up. Staying well hydrated, being mindful of your mental health symptoms, and then a stool softener as needed for constipation. This medication may also require a PA, like we mentioned, but if it is not covered by the insurance, you can go directly through the pharmaceutical company, and the pharmacy may have to order this. A lot of times they don't keep this in stock, but it may take a week or two. They should have that. So that is actually the end of today's part of the presentation. The other half will be next week, and we'll talk about GLPs, GIPs, anything to do with that. But what questions, concerns, comments does everybody have?
Yes. Kelcie, do you commonly start with these options or no?
Yeah, these are kind of the starting oral medications. Now, I will say if someone is already diabetic, if they have coverage for a GLP-1, I tend to go more towards the GLP-1s just because the studies and the percentage lost. I mean, you're looking at, with these, 5 to 10% of weight loss. With the GLP-1s, even the least effective, I think, is around 17%. So if someone is dealing with pretty substantial obesity and they have GLP-1 coverage, I'll kind of go in that route. But these are a lot of really great options for people that, one, are just getting started on weight management, don't have a ton to lose, or cannot get coverage for GLP-1s.
Well, good question.
Anything else?
Thank you, Kelcie. It's a very, very good presentation. Mm-hmm. So we'll do the next week, second part, same time, 12:30 to 1 o'clock. And thank you so much.
All right. Thanks, guys. Have a good week.
Good week. Bye-bye.
Yeah, thanks. That's absolutely fabulous.
Hope you liked our detailed video about obesity treatment and medication. See you soon. Hope you liked our detailed video about obesity treatment and medication. See you soon. Hope you liked our detailed video about obesity